Greetings all. Welcome and thank you for joining this HSR 2020 satellite session on expanding digital financial services for health to support the scale-up of universal health coverage. Slide, please. I'll start with a quick introduction of our speakers and the format for the session. My name is Sri Bakaran and I'm a Senior Technical Advisor for Health Financing at Palladium. I'm joined by my colleague Liz Narad, who is a Director for Digital Solutions at Palladium as well. Next, we're very fortunate to be joined by Nji Ndili, Country Director for Farm Access Foundation, and Matt Guilford, Co-founder and CEO of Common Health. Lastly, we have Arin Dutta, who is Senior Technical Director and Health Economist at Palladium. Next slide, please. Our agenda for the next 2 hours is as follows. I'll start with an introduction to digital financial services for health, why it's important, how it pertains to UHC aspirations, and what potential it has, particularly in the current moment. Liz will take us up level to explore the DFS ecosystem, discuss applications outside the health sector, and some of the enablers and barriers to increased adoption before she poses some key considerations for DFS to support the UHC agenda. And Jide will present on the role DFS has played in advancing the UHC agenda in Nigeria, working in concert with state-based health insurance schemes, along with application in Kenya. And finally, Matt will present on the role DFS can play in health systems context where UHC reforms are more nascent and there is a large scope for private sector intervention. We'll touch on applications in Bangladesh and Myanmar. Arin will lead us through a moderated Q&A, starting with results from a couple of poll questions we shall pose between the country presentations. We look forward to a lively discussion at that point. Next slide, please. So why are digital financial services for health important? Because there is still a significant proportion of the global population who are unbanked. Data from 2017 indicates 1.7 billion people globally do not have a bank account, 65% of adults in the developing world. This is down from over 2 billion people in 2014, but still a significant number of people who face challenges every day to transact and save, but also to access healthcare when needed and avoid catastrophic health expenditure. Nevertheless, 2/3 of this 1.7 billion people own a mobile phone, and that could help facilitate their access to financial services and products that support their health. Millions of the digitally connected but unbanked people live in just a handful of countries, and we'll hear more about DFS 4H interventions in Nigeria and Bangladesh in today's session. DFS 4H has the potential to bring the unbanked along the journey to UHC. Next slide, please. Now that we've quantified who the target population is for DFS 4H interventions, it is important to understand some of their characteristics. We can see here that there are twice as many unbanked adults in the bottom quintile compared to the top, and 50% of all unbanked populations belong to the bottom quintiles. Unbanked adults are also more likely to be women, highlighting a gender disparity that may affect access to resources for healthcare and that could be corrected to some extent through the autonomy and empowerment delivered by a mobile phone. In the third chart, you can see that 72% of unbanked are out of the labor force, unemployed or self-employed. In other words, being unbanked is a characteristic of the informal sector, which is also the sector that has proven hardest to reach with UHC reforms such as national health insurance schemes. DFS 4H offers the potential to bridge that gap. And lastly, we can see that almost 2/3 of the unbanked population have a primary education or less. This is important when considering the design and complexity of DFS 4H offerings and something my colleagues Njide and Matt will touch on further. When we consider these characteristics together, we can see that the unbanked are likely to face greater health risks and are more prone to catastrophic health expenditure. Next slide, please. Now that we have seen the scale and complexity of issues associated with unbanked populations, what are digital financial services and why would they be of use? Broadly, digital financial services refer to financial services such as banking, insurance, payments, investments that are accessed or enabled by digital channels, including phones, computers, electronic cards, and vouchers. My colleague Liz will explore the state of these various applications in more detail. So at this point, I'll just hint at a few of the preconditions for successful application of digital financial services. First, there is a need for reasonable mobile phone penetration and potentially smartphone penetration for more sophisticated DFS applications. However, as Matt will attest, there is much that can be done even in contexts with limited smartphone penetration, such as Bangladesh. Next, reliable internet and mobile data connectivity and affordability is a critical enabler, and one that also ties into the last factor listed here, which is appropriate regulatory landscapes that facilitate unique, secure identification of users. This will underpin the security, reliability, and thus acceptability of any DFS4H platform or service. Next slide, please. So why are DFS increasingly important? Well, I mentioned at the beginning that those who are unbanked, 2/3 of which have a mobile phone. In fact, that proportion is expected to increase significantly. The extension of mobile phones and digital connectivity is continuing to increase at an accelerating pace, far faster than the rate of traditional banking and financial services. This creates an opportunity to leverage technology to deliver digital financial services for health. You can see on this slide some of the projections made by the GSMA in 2020 for the level of growth that we see by 2025. A fourfold increase in global mobile data usage. And in Africa, that's actually projected to be eightfold. 1.2 billion additional mobile internet users are mostly projected to come from Asia and Africa as well. And while to date, growth in mobile phone usage in developing countries has been driven by affordable basic phones, smartphone adoption is rapidly increasing, along with the infrastructure connectivity upgrades to 3G and 4G services. Next slide, please. So given the need expressed by the significant unbanked population and the tailwinds for digital financial services adoption, how do we apply DFS for health? Next slide. I think it's first important to recognize what's come before the relatively new field of DFS for health. mHealth has been around for over a decade and is defined by the WHO as simply the use of mobile and wireless technologies to support the achievement of health objectives. You may all be familiar with several of these applications, from electronic health records to HRH planning tools to inventory and supply chain management platforms. At the same time, financial inclusion for health has also been a focus for next slide, please. At the same time, financial inclusion for health has also been a focus for quite some time, with many health financing reforms focused on strengthening both supply side and demand side financing. Historically, these reforms often have minimal reliance on technology, such as a voucher scheme for the poor to access specified health services at a nearby clinic, or a village savings and loan program. In other instances, these reforms try to correct for the issue of being unbanked or underbanked through the provision of microcredit or insurance. However, due to the verification required to engage with formal financial services, these often operate at low volume and lack the ability to scale beyond a discrete intervention with a known set of beneficiaries. Next slide, please. We can think of digital financial services for health as operating at the intersection of these two fields, addressing some of the issues that historically faced financial inclusion for health programs by leveraging the accelerating rate of device adoption and connectivity among beneficiary populations, and also facilitating links to more traditional mHealth areas to support a strengthened health system and the UHC agenda. Next slide. So how can the DFS for health advance the UHC agenda? Here, we've listed several examples of how DFS can be applied to health in ways that increase financial protection, expand population coverage, increase access to essential services, and create a more responsive and accountable health system. Some of the key benefits of digital financial services for health include enhanced security for healthcare-related transactions, improved confidentiality for patient data, increased speed and efficiency of payments with less opportunity for theft and leakage, ease of scaling solutions to all populations meeting the minimum preconditions for access, and increased accountability of health system providers through payments for quality. Next slide, please. For DFS applications to be scalable and sustainable, they will eventually require integration into a national health information system architecture. Secure identification of users will likely require any DFS for health applications to be linked with civil registries and insurance verification systems. Applications will also need to verify information with various health information systems, such as electronic health records, master facility registries, and health worker registries. Next slide, please. I'd now like to highlight why the moment is now to seize on the opportunity to expand digital financial services for health. Many governments and donors are formulating their policies in relation to digital financial services, acknowledging the rapid acceleration that was already underway that was further boosted by the advent of the COVID-19 pandemic. Indeed, McKinsey suggests that in the second quarter of 2020, as the world went into various stages of lockdown, digital adoption accelerated by 5 years in the space of just 8 weeks. We've seen governments leverage digital infrastructure to deliver massive stimulus programs that have increased financial protection for health. They've also taken the same moment to update government databases for beneficiaries, addressing exclusionaries that had previously prevented access to subsidized care for millions. Notable examples in this space include India and Pakistan. We've seen efforts to counter the drop in facility visits for non-COVID-19 related healthcare with expanded healthcare to access to telemedicine and health monitoring services, with associated restructuring of digital payment practices for insurers and patients to facilitate the surge in digital usage. We've seen incentive schemes put in place to support frontline workers, with top-up pay often facilitated through digital technology to ensure it gets to the worker quickly and accurately, having learned from the successes of this intervention in Sierra Leone during the Ebola crisis. And lastly, we've seen governments acknowledge the economic fallout of the pandemic with efforts to ensure loss of employment does not result in loss of insurance coverage, along with efforts to specifically target informal sector workers through digital means to facilitate their health insurance. Some key factors that the pandemic highlighted include the need for robust national ID systems to ensure transfers are efficient, accurate, and timely. The ability for digital transfers to encourage new users to engage with DFS, familiarize with the convenience and functionality it offers, and ultimately earn their trust so they continue to leverage the technology for various means, including health. And lastly, the benefits to payers in using secure, scalable digital transfers and leveraging DFS to collect relevant data, such as health savings account usage and balances. These factors all go well for continued scale-up of DFS for health in support of the UHC agenda. I'll now hand it over to Liz, who will go into more detail about the DFS ecosystem, some of the enabling factors that have led to increased adoption of DFS, and considerations for applying DFS in the health sector. Thanks, Liz.
Excellent. Thanks so much, Shri, for that introduction and for an understanding about how digital financial services for health can really push the UHC agenda. As Shri said earlier, my name is Liz Neerad. I'm a director of digital solutions at Palladium. I work with a team of digital strategists and technologists working to accelerate the adoption and the use of digital technologies really for positive impact and for international development goals in general. So what I'm going to do in this section, as Shri said, is take a step back to look at sort of the 30,000-foot view of the digital financial services ecosystem. I'm going to talk a little bit about the important role that digital financial services play in international development in general, walk through some use cases and some examples of that, especially in regard to achieving the Sustainable Development Goals. I'll give a little bit of a landscape of the current mobile money industry right now, building off of some of the stats that Shri shared earlier. And finally, I'll end with looking at the digital financial services ecosystem and how we can build off of what has been enabled over the last several years, really in the health context, to help us advance progress towards UHC. So to look a little bit deeper into digital financial services and the achievement of global development goals, there are several ways in which we see DFS really supporting digital or global development goals in general. So first, at the micro level, digital financial services help to enable financial inclusion, right? These are the stats that Shri started with at the beginning of his presentation. So this is really access to and use of basic financial services, which can help us to reduce poverty, increase resilience, and improve the lives of the poor, particularly women, providing economic empowerment. We also see DFS playing a big role in the social protection and humanitarian response space. So we see this with cash-based benefits, benefits that go towards supporting displaced people or refugees, and really seeing that as a means to scale cash disbursements. We also see that digital financial services can increase the efficiency and the productivity of other sectors. So what do we mean by that? Well, simply switching from cash to digital means is more efficient. So it's easier to pay a health worker through digital means. We saw that highlighted in the Ebola crisis, being able to get payments to our healthcare workers who needed it without having to come into contact, and potentially put other people at risk. We also see this in administering subsidies to small scale farmers, et cetera. So it really just makes everything more efficient, switching from cash to digital. We also see digital financial services helping to improve government accountability and transparency. With a digital means, we have a paper trail. Well, actually not a paper trail, but we have, a digital trail that can be tracked to see traceability of payments and reduce leakage. And finally, at sort of the macro level, we see just switching to a digital economy helps bring more money into the formal economy in general, and has shown it's shown a contribution to increasing GDP of countries. So I won't belabor this anymore, as we know that digital financial services and inclusion play a huge role in catalyzing development progress. There are several ways that have been really highlighted for how DFS encourages and really catalyzes improvements and progress towards the SDGs. So I'll just highlight a few here. We see DFS being used to help families cope with shock and receive government payments, can help to prepare for unexpected healthcare costs through microinsurance. We're going to talk more about that with my other colleagues and panelists today. We also see an opportunity for DFS to provide better granular data, especially especially about people and about products that generally we do not have good data on. So this is better data about women that can help us to inform better policies and products. We see DFS being used to be able to collect taxes efficiently to prevent leakage, as I mentioned previously, by having transparency throughout the financial services value chain. Finally, there's even the opportunity for DFS to support helping us mitigate the risk of climate-related disasters, helping us make purchases and investments of environmentally friendly products. So it's clear that there are many ways in which DFS really helps us to catalyze our progress for our development goals in general. So now let's take a snapshot of digital financial services in general, particularly the mobile money space I'm going to focus on, so we can kind of understand what these opportunities and challenges are to reach scale. So by 2020, over 5.2 billion people had subscribed to mobile services, which accounted for over 67% of the global population. So over 2/3 of the population now have access to mobile services. Nearly 2/3 of this growth has been in the Asia Pacific region and in sub-Saharan Africa. And this is where we expect to see the most growth by 2025. We expect to see almost 610 million more subscribers globally to mobile services. So what does this mean? This means that the areas that are, particularly where there are the unbanked, as Shri mentioned, and also particularly where advancements in UHC could be really catalytic, they are actually having access to mobile services, whether it be access through a smartphone or through more basic technologies. For those of us following this space, we also probably heard that there was a pretty monumental milestone within the mobile money industry at the end of 2019. So mobile money accounts surpassed 1 billion worldwide. And now mobile money is processing almost $2 billion a day. And where we see the most significant growth in these areas is in sub-Saharan African region, in East Asia and the Pacific, and in South Asia, which are also the key areas that we are focusing efforts on for UHC. So this shows that mobile money is becoming more accessible and being adopted. But despite this growth, what we also see is that only 36% of registered accounts were active in the last 90 days. So while we do see adoption and use, this does indicate that mobile money has not necessarily become the de facto way of payments. When we also look at the mix of mobile money transactions, we do see that more money is staying within the digital ecosystem or the digital economy, with almost half of mobile money transactions, or a little bit more actually, staying within the digital economy. But what we see here as well is that almost half still are cash in, cash out. So when we look at also at the mix here, we can see the different types of transactions. We see that peer-to-peer transfers still represent the largest value of mobile money transactions, both globally and throughout Africa and Asia. So we can sort of think about mobile money on a maturity scale and digital financial services on a maturity scale in general. So we can consider payments at sort of the most basic use case and the most basic way to use mobile money, all the way building up to savings, to borrowing or lending and credit, insurance and investment, and potentially even being able to use digital financial services for advisory services or consulting. So what we see now in the current landscape and what the previous data shows us is that mobile money is still primarily being used for payments. But we do see progress in these areas. We see that from 2018 to 2019, there are now 39% increase in mobile money being used for savings. There are now 26 million unique customers that saved via mobile money in 2019. For borrowing or for lending, we see that there are more deployments being offered that provide credit. So this increased by 25% in between 2018 and 2019. And we also see that there are more insurance services that are being offered. 102 now, or at the end of 2019, there were 102 mobile-enabled insurance services across 27 countries. So again, while we see primarily that mobile money is being used for payment and is being used in a cash in, cash out sort of way, we do see that both from the supply and the demand side, there's increases up this maturity sort of scale. So now let's think about how the digital financial services ecosystem works and how do we leverage these advancements and the progress that has already been made in this space. So first, I'm going to set the stage to have us look at the digital financial services ecosystem in general. It's comprised of many actors and functions across the value chain with many interactions across all of these stakeholders and services throughout. So at its core, we have the customer who makes the payment or receives a digital financial service. We have network infrastructure that enables connectivity across this value chain. We have the digital transaction platform enabling customers. This is the technology that enables customers to make or receive payments. We have the services and the businesses that are providing those services, whether they be credit, savings, securities, loans. We have the financial institutions. They hold the money, the risk rating, credit, et cetera. We have retail agents. They enable customers to convert money, cash in and cash out. And all of this is enabled through a mobile device, right, which is used by both the customer and the agent and really everyone across this value chain. So we've seen this significant progress and really this foundation that has been built within the digital financial ecosystem. And this has really been enabled by several key factors across infrastructure, technology, policy, and the regulatory environment. So some of these things that have made this possible are, when we think about people or consumers, we know that digital and financial literacy is increasing. We know that cellular network connectivity is expanding and is more accessible. Mobile phone penetration has increased worldwide, both smartphones and basic phone technologies. We've also seen advancements in technology around APIs and interoperability that have really facilitated this information sharing across financial institutions and offered, an entry point for new services to plug in and to be able to share information. From a regulatory perspective, in some cases, regulation has enabled non-bank e-money issuers, so not having to go to the actual bank to receive a financial service or credit or loan and having that be done through agents, which has really allowed for expanded reach of financial services and promoted financial inclusion. We also see that in general, transaction costs have decreased. So this has lowered the barriers of entry for both consumers and enterprises to transact within the digital economy. And finally, another driving piece of all of this is that we have more data, right? We have more data. That means we have better insights into our customers, and we can better tailor products based off of customers, which then continues to drive an increase in demand and an increase in the services being offered. So now what does this mean in the health context? How do we take all of this and leverage the foundations here, but kind of layer the perspective of health, especially in service of enabling UHC? So there are several key considerations and challenges that I'm going to leave us here with today as we segue into the country applications and the programs that my colleagues will share more about as we think about scaling and really building off of the momentum within the DFS space in general. So I'm going to talk about this in thinking about this in three ways: thinking about the patient, the provider, and also the payer. So there's still more that needs to be done to motivate, to encourage, and to empower people to take charge of their health and to save for health. This is a behavior change component that we need to address. As we've seen in the previous data, mobile money is not necessarily being used for savings, and savings isn't necessarily something that comes naturally. So we need to be doing more to be layering not only digital literacy, financial literacy, but also health literacy on top of that. And really, digital financial services for health is at sort of that sweet spot of the trifecta of those areas. We also need to ensure that as we're using digital financial services for health, we're really ensuring that the most vulnerable populations are reached. That means both with networks, with devices, and also just within the ability to access the services that they'll be attaining through the financial services or through the actual health services that it enables. We also have added complexities about patient identification. We know that digital financial services have helped to promote digital IDs and biometric usage in some cases, although there's still challenges there. When we have the added layer of health data on top of that, we have a whole nother layer of complexity around privacy and confidentiality, and making sure that confidential data remains private and secure. From the provider side, we have to look at this from two different perspectives. We both have the provider of the digital financial service, or of the insurance in this case, and we need to be thinking about what are those sustainable business models that make sense to provide those services. And we also have to think about healthcare providers. How do we bring in healthcare providers and interconnect them within this ecosystem so that we can know what services were provided, who they were provided by, and where they were provided. We also need to look at how, as Sri mentioned, how do digital financial services really align with the country's national digital health architecture and reduce fragmentation that already exists across information silos. And this really gives us, to the big question of really who pays for health services, and how do we integrate DFS into kind of a digital first model for UHC at national public scale. Digital financial services can help to enable UHC, but it is not necessarily a panacea, and it is something that we need to have be integrated in, to the public health financing scheme in general. And finally, as we have more access to data, as I mentioned on the last slide, we have a real opportunity here to make sure that we're using that data, providing feedback loops to ensure that our target populations are reached with the right products that really enable quality and equitable health services in an efficient way. So hopefully I'm leaving you here with some considerations that you can take forward and think about throughout the rest of the session today, as my colleagues will share more about their programs and how they're integrating digital financial services for health in their programs, and look forward to the discussion perhaps around some of these key considerations as well. Thank you. And now I'm going to pass it off to
Thank you, Liz. Thanks, Liz. That was really excellent, and thanks for drawing out some of those DFS enablers, but also acknowledging some of the usage challenges and how they apply to the health sector. I think that sets us up well to now go through some in-country applications. I'll hand it over to Njide to discuss Pharmax's work leveraging DFS to advance the UHC agenda in Nigeria and Kenya. Thanks, Njide.
Hi, sorry about that. Let me just share my screen really quickly. Just to mention, 1 second, resume share. Can you see my slides?
It appears to be frozen.
Oh, it's frozen. Let me try one more time. And Or Georgie, maybe you can take over because I'm having a problem sharing it. It's not, okay, fantastic. Thank you so much. There's always issues with technology. As I was introduced earlier, my name is Njiden Dili, and the country director for Farm Access Foundation based out of Nigeria office. Farm Access Foundation is an international NGO, and we are currently in 5 African countries. We're in Ghana, we're in Nigeria, Tanzania. We are also in a few other countries like Liberia with some of our products. So I think Liz and Shri have laid the foundation to give some practical examples, but I want to start by kind of giving the background and how UHC, Universal Health Coverage, interfaces with digital financial services. Next slide. So I wanted to paint a picture. For those who have heard about Nigeria, always it's negative information in the press. But unfortunately, when it comes to the healthcare system, we try to look at the pillars that create either the efficiency or the inefficiency in healthcare service delivery. So when we look at the demand side, there's a lot of fragmentation and limited pooling of funds. There's a lot of out-of-pocket payment. In fact, we have one of the highest out-of-pocket payment with almost 95% of the population paying out-of-pocket. And of course, this affects really the poverty rate, because the more out of pocket you pay, the more impoverished you are. Then on the supply side, there's a lot of, there's limited investment, low quality, weak monitoring system, even the access points are very restricted. Then you top that up with the patient's behavioral, healthcare, poor-seeking behavior, health-seeking behavior, and the lack of trust that the patients have in the system. Now, this is kind of a vicious cycle, because the low level of trust in the healthcare system results in the low investments and results in the patients not wanting to go into the healthcare facilities. Then cap that up with the governance structure, where we have very weak governance system. So if you look at all of this, it's a recipe for what I would almost say disaster. So as Farm Access, what we're trying to do is to go back, take a step back and look at what the issues are that are creating the bad indices that we have and the healthcare systems that we have, and begin to address those one pillar at a time, and as much as possible infusing technology or mobile technology within our activities. Next slide, please. So just again, to give a context, Nigeria is a country of about 36 states and the Federal Capital Territory. Almost all the states, 35 of them, have passed mandatory health insurance laws, except for one, which is still going through that process. But even at that, it's not about passing the law, it's about implementation. We have less than 5% of the population covered by any kind of insurance. And the out-of-pocket payment, even though the official figure says 70%, but we know that it's close to 90%, because you go to the hospitals, they actually ask you to make a payment or deposit, sometimes when you have insurance. So these are some of the things that we are trying to change by supporting the government. And of course, the population now, Nigeria is the #1 poverty capital of the world. Over 70% of the population lives on less than $2 a day. So you can imagine the impact of that. And on top of that, health is on the concurrent list. So it's the responsibility of the federal, state, and local governments to administer health at different levels with different responsibilities. So we have the regulator, who is the National Health Insurance Scheme. We have the community-based health insurance schemes. We have the HMOs. And again, this has been devolved to the states to take ownership of the implementation of their mandatory health insurance schemes. Just to put it in context, next slide. I won't dwell too much on this, but it's important to have a framework in our support to state governments. We support quite a number of state governments to achieve UHC. And we find that so many of the different states are different stages of implementation. So when we go to them and start discussions of support, we have a framework. Do we support you with baseline, or do we support you with legislation or policy development or scheme design, which is really where the expertise comes in, as well as scheme implementation. Next slide. So our approach to UHC really is to find a way to ring fence funds for care, to find a way to start from the bottom up. Because if you look at Nigeria, it's a pyramid. You have the small percentage at the top who are extremely wealthy, who fly out of the country to receive care. In fact, we have $1 billion leaving Nigeria every year on medical tourism. But then you have the mass at the bottom who don't have any access to care at all. In fact, Nigerians die more out of either no care at all or bad care. So you can imagine the systems that are lacking. At the same time, we have quite a number of implementation partners, donors, so many vertical programs. So what we're trying to do is find a way to integrate quite a number of these vertical programs into a horizontal insurance program so that we are able to achieve UHC, but not just implementation of the insurance scheme, but starting at the baseline of system strengthening on both the supply side and behavioral change on the demand side, using some of the tools that are already available, which includes the mobile phone. Next slide. So this is just to give you a scope of where we are. We are in over 12 states, some of them also in partnership with several partners implementing at different stages to achieve, of course, with the same goal, either strengthening the health system with the involvement of private sector, or experimenting, testing proofs of concept of what might work, but with the ultimate goal of achieving UHC with the ownership by government, because we still believe that achieving UHC cannot be done by private sector alone. It's the government that has to hold the rein to be able to achieve that. So next slide. So I wanted to go ahead and give some examples based on what Sri and Liz had talked about before, because we really believe that technology has a huge role to play. If Africa is going to achieve universal health coverage, it has to be done using technology. And it's not, the big robust technology, but really light technology. There's a lot of innovation coming out of Africa. In fact, we are leapfrogging quite a bit, as you must have heard. 10% of the GDP of Africa is running through the mobile phone, which is far in excess of what is happening in developed countries, Europe and the United States. But so these are some of the uses of how technology can help achieve UHC. One is fragmentation. Through the phone, you can actually mobilize local funding. You can mobilize resources. People can transfer money to one another. Donors can put money in wallets. You can also identify the individual, which is a big problem in Africa. We don't know ourselves. We can't even identify ourselves. Nigeria currently is going through what you call a national identification number registration, which is going to be tied to your phone. So in another month, they're going to switch off all mobile phones that haven't been tied to a national ID number. So you can imagine the impact that would have. It's all over the news. People are scrambling, even with COVID. So, there's a lot of criticism around that, but the mobile phone can help you identify the individual or give the individual a voice. So that is very key. Then in terms of administration cost and transparency, it's just a marginal cost to be able to reach people. Nigeria, a country of 200 million people, we have 169 million active phone lines. In fact, 70% of the adult population has a mobile phone. So why can't we leverage on that technology in order to, create access to care as well as other amenities and benefits. Then of course, pay for performance. This is now on the supply side. And most important is data. Decision making using data is actually quite lacking now because that data is not being collected. So technology is really an enabler in this case if we're going to achieve UHC. So I'm going to now go into specific examples of what we have done because as Pharmac says, we are not just a recipient of donor funding, we are also an implementer, and we also put our money sometimes into programs just to prove that a concept works. So next slide, let's, so the first use case I will talk about is CarePay. For those who are familiar with CarePay, it's also called MTIBA in Kenya. Now, for those who also understand the economy in Kenya, MTIBA is layered on M-Pesa. M-Pesa is a mobile money platform in Kenya. But with a partnership between PharmAccess and Safaricom, we are able to develop a wallet which holds the savings for enrollees, those who are interested in accessing care in the healthcare system in Kenya. In Nigeria, it holds the insurance. In Lagos State, this is what we have rolled out to the Lagos State government. So it is a platform that connects the policyholder, the payer, as well as the healthcare provider, such that you can almost literally have real-time flow of data, flow of funding amongst the three. And if you look at the image on the left, which shows what the situation normally would be, is that you have donors paying providers, you have individuals paying providers, you have government also paying providers. So there's a kind of a spaghetti situation going on there. But if you were to channel this through a wallet in the mobile phone of the user, then you can already cut out layers of administrative bureaucracy and wastage because the money goes directly to the patient. And now the power moves to the patient where they can already authorize their care. You as the administrator, you can tell when the patient has gone into the clinic and better able to manage their care in that regard. So this is the first use case. Next slide. This is again the same situation in Kenya. The National Health Insurance Fund in Kenya is using it for registration, premium payment, patient management, as well as claims management. And to give you an example of patient management, for pregnant women who are using MTIBA, you go for your antenatal visit, you open your phone authorizing the first care. We know that you have to attend at least 4 antenatal visits. If you miss the second one, we already know that there's something wrong. So we either contact you or the provider contacts you asking if you're okay. So you can better manage the patient journey using their mobile phone. Next slide, please. Then this is just to show the dashboard of the different views. So as a participant, you can see your wallet, you can have access to it. You can actually have multiple people giving you money or donating money into your wallet, as well as your own savings. This is the situation in Kenya. In Nigeria, it's just insurance because Nigeria is kind of a pay-as-you-go economy. We don't believe in savings. And besides, the cost of service oftentimes is quite high, that for those who are extremely poor, I mean, it will take you forever to save to be able to access care. So we are promoting insurance instead of savings. Well, of course, you can save to buy your insurance. So this is what is going on, especially with the fact that in Nigeria, 35 states have passed mandatory health insurance laws, of which within that law, 1% of the consolidated revenue of each state is designated into a fund to pay the premiums of those who can't afford to pay. And all this can be monitored through the mobile phone. Then you have the provider interface and the payer interface. So example, the National Health Insurance Scheme can see how many people have enrolled in one day. And all this is collected through the mobile phone and displayed on a dashboard in real time. Next slide. This is just to show numbers. So in total, we currently have over 4.7 million lives on the CarePay platform, both in Kenya and Nigeria. We have over 3,000 providers on the platform, and millions of dollars in transactions have gone through this platform because we can now see the encounter, we are administering the claims and so on. So again, it better helps you to price your products, the premium. It better helps you to organize and design and improve the system, which is beneficial to the population. Next slide. Second case use, I mentioned earlier that each state, when they passed their law, designated 1% of the consolidated revenue to pay for those who cannot afford to pay. So if you're in Nigeria, you quickly become poor. So there has to be a methodology that allows you to be classified as being eligible for a subsidy or total premium payment. And this is the multi-method poverty screening tool, the PPI tool that we are using. This has been integrated into the mobile platform. It's a series of questions that you're asked, how many rooms in your house? Do you have a pit toilet as your convenience, or do they're basic questions, and it's a world-class process that we have adopted. We just digitized it, and based on your responses, the system would then throw you into an enrollment process so that you can enroll for the health insurance scheme, or it will ask that you pay the premium for yourself. So this is another important tool. And in fact, we are now collaborating with the government of Nigeria because this tool can also be used for additional benefits, conditional cash transfers to indigents and people who most need it and cannot afford healthcare services. Next slide. This again is another very important tool. This is what we call the mobile application for tuberculosis screening. Now, Nigeria is one of the countries with the least ability to identify tuberculosis cases. So in working with Global Fund and IHVM, which is Institute of Virology, I think head office in the United States, we supported to design this application. Now, interestingly, when we started, it was really to run this algorithm so that we can screen for TB. But so far, it's been adopted by the National TB Program in Nigeria and used in 22 states. But we have integrated it not only to the poverty mapping tool, but we're now integrating it to the CarePay platform such that if you're being screened for TB, at the same time, we check what your eligibility is in terms of whether you can receive subsidy to enroll in a health insurance scheme, or whether you can pay for yourself. In fact, Global Fund has even opted to pay the premiums for those who cannot afford to pay, identify through this process, especially if they have TB. So again, you can see a variety of uses being streamlined into one application. Again, the ultimate goal is how can we leverage all the different funding streams into one stream that leads to universal health coverage and the coverage of the individual as a whole, as opposed to disease profiles. Next slide. So this is just showing the states where the tool has been adopted. In 6 months, we screened over 300,000 people. So you can imagine the scope. It's on the phone and it's being used by healthcare workers and health extension workers. So there's really no extra work to be done except going through the algorithm. And we've identified some presumptives and have some people under care. So again, this is the power of a digital tool and how you can integrate that into additional benefits for health. Next slide. Then, of course, it's COVID. That is what is going on. We, of course, because we are in the field implementing, supporting quite a number of facilities on the supply side, and supporting the state government like Lagos State to provide care and to market and implement the insurance program. We came up with a system which was meant to provide free digital service in collaboration with one of the federal medical centers, FMC Ebutemeta, as well as Lucy Technologies based out of Amsterdam. So it's really a simple app that you can download from the App Store, monitor your symptoms, so it guides you through. And if you have, based on the algorithm, you're a high risk for COVID, it immediately directs you to the healthcare facility where you can get tested, you can get isolated, you can get treated, and this is all for free. Again, just showing the power of leveraging mobile technology. And on the next slide, you will see the numbers as it were. Next slide. So in less than 3 months, when we started, we were able to reach, through digital marketing, over about 2 million people, but the people that actually clicked and reached out in terms of communication that were interested based on the Facebook clicks and all that were over 500,000. And those who downloaded the app, 42,000 from, so this is, again, we were using the app to communicate information about COVID, because there was a lot of negative information, disinformation. In fact, in Nigeria, they said there's no COVID, they're lying. The government is just trying to make money and steal away the money that they're getting for support. So we were using this medium to correct the information, but also to educate people, but then direct them on where they could get services. But again, even though it was such a noble project, I can tell you that, again, this is where what you call learning comes into play, understanding the thinking around the poor, those who can't afford to pay. They were very skeptical that, this is not, there's something behind it, it can be free, and so on and so forth. So again, with mobile technology, you're able to either correct information or reach out to people who ordinarily you will not be able to reach out to. So I think this was a very important project that we started that has now been adopted by the hospital itself. In fact, they've used it to create a call center to care for COVID patients and to do home monitoring through that call center. Next slide. Then the fifth use case, which is also very important, is digital lending. For those who work in lower middle income countries, you know that a lot of the healthcare facilities are SMEs. They're owned by mom or dad, or by a single individual who is unable to access funding through a bank, through a formal process. What we've also found through a medical credit fund, which is a fund of about $40 million with investment from Calvert Foundation, investment from the World Bank, IFC, is to catalyze investment in the healthcare sector, to give banks and financial institutes a level of comfort so that they're able to lend to SMEs. So we do a lot of capacity building, not just of the banks, but the healthcare SMEs. So what we found is that there's usually lack of structure, governance, financial management systems, and so on. So as part of our support, for you to access the loans, you have to put in some of this system, which includes a financial management system based on technology. And this has allowed us to not only to see the transactions within the healthcare facility, but to extend cash advances and digital loans, which they ordinarily wouldn't have gotten from a bank. So we are seeing this increasing. It's far advanced in Kenya, and Nigeria is just starting up. And this, again, is through partners with really negotiated interest rates so that it's easy for healthcare providers to access to have access to finance to improve quality within the healthcare services. Next slide, please. Then this one, the Health Remit, or we call it Health Connect, is a very important one, especially in Nigeria, because there are quite a number of Nigerians outside of Nigeria that are sending money on an annual basis into Nigeria. And based on our research, a significant amount of the monies being sent into Nigeria is to pay for healthcare services. Last year, I had the opportunity to speak to the Nigerian doctors in the UK, the association MANSAG, over 200 doctors. And I presented this idea because we wanted to test it to see that if we created a transparent channel for you to pay for healthcare services for your relatives in Nigeria, where you can pay for the insurance directly by yourself and make sure that all they receive on this side is access to healthcare services, would you do it? And the answer was emphatically yes. So this is a way to support, we're currently piloting in Lagos, and it's a way to support and aggregate the fund so that it's not in a different pool, but the fund goes into the Lagos State Insurance Fund, where the resources are pooled together and the risk is shared, right? And everybody, this also allows those who cannot afford to pay to access care. So we are testing this, and it seems quite interesting, as it were. Again, using the mobile phone, nothing more than that, to channel funding from the diaspora directly into a health insurance scheme. This is one that we are also now discussing with Global Fund, because quite a number of donors want transparency. They want to know where their money is going, or even who the money is going to. Of course, a lot of this data is going to be blinded when it comes to utilization, but at least there's a comfort level that the funding is used for what it was meant, designated for. So this is another use case. Next slide, please. So implementation approach, I'll just rush through this. Next slide. Really why we are focusing on technology now, especially mobile technology. As I mentioned before, over 150 million mobile phone lines. And the generation, when I call Nigeria, out of the 200 million people in Nigeria, 60% are actually aged less than 35. We're a very young population. And this population is actually quite active when it comes to social media and using digital devices. So our thought process is, how can we utilize a device that's already in the hands of the people? Quite a lot of it smartphones, but there are also feature phones, which we tailor our innovations to make sure that they cater to those that have feature phones. Then, of course, the pandemic has pushed the adoption of technology forward. So we want to leverage on that. Health has been the sector that is so behind in digital adoption. So we are using this momentum. So now, in Nigeria, as well as Kenya, there's a wide adoption of telemedicine platforms, sending money for payment for healthcare through the phone, payment for services through the phone, even utilization monitoring and dashboards through the phone. This is part of the reason why we want to make sure that we seize, the benefit of this pandemic and not waste it. Next slide. Some inhibitors, I won't dwell too much on this, but in Africa, even as these adoptions and innovations are being developed, we realize that the regulators lack the capacity, first of all, to even understand some of the innovations and the benefits of the innovation going on. So we find that developmental partners and private sector is far ahead of the regulators. So there's a need to, make sure they're being carried along and brought up to speed so that they understand the benefits of some of the work that is being done. There's a lot of fragmentation. So everybody is, you have enough to just start your own innovation, but there's never enough funding or support to scale it. So, because of that, there's very limited interoperability, data protection, and so on. So there are quite a number of issues, I think, that as partners, as a private sector, that when we are pushing innovation, we should just ensure or try as much as possible to take a step back and see how we can support or advocate for either policy or infrastructure or digital literacy or access to finance to enable some of these innovations at scale. Otherwise, it's a nice concept, it remains on paper. There's so many in Africa, and I think that has to change so that we can actually have the benefit of some of those innovations to achieve UHC. Next slide. Next slide. Okay, so these are just dashboards to show some of the data that we're seeing, enrollment, registrations, utilization, policy. All these are on dashboards, and we at the back end, we're looking at it and trying to advise. For example, you can look at KW, which is Kwara State Government, one of the states that we support end to end. They started enrollment in May, then all of a sudden the government, who was now in the lead, said they had no additional funding to commence enrollment again. Then we support them to help develop marketing strategies and train their people and so on and so forth. Then enrollment starts again and shoots up. So based on some of these dashboards, you can then determine where targeted support is needed. What are we seeing to help define the policies or the regulation or even the benefit package? For example, 80% of the encounters that we're seeing are predominantly primary care, aches and pains, and so on. So even though there's a push for cancer within the country, cancer was not included in the benefit package because of the kinds of data that we are seeing. And all of this is on a dashboard and very easy to access, collected through mobile data. Next slide, please. Same thing with Kenya. We're seeing the same thing. In fact, in Kenya, which is far advanced, there are dashboards in the regulators' offices. So they even have a tracker for some of their enrollment officers. So if there's no enrollment going on in one county, then they're asking where using GIS maps, where is the person responsible? So a lot can be done using mobile technology. Next slide. This again is showing patient encounter, how people are using the system. Initially, of course, there was a lot of out-of-pocket payment. Then within a certain location where we started, and over time, the out-of-pocket dropped down and it moved to insurance. People were starting out with 4 encounters a month. Then when they realized that insurance is here to stay, they were testing the system. And of course, they back off and only go to the hospital when they need it. So a lot of this information helps you target your support and helps you target the kinds of support that are given, not just to the providers themselves, but also to the patients, and helping behavioral change. Next slide. I think so that's the last slide for me. But again, there's so many other innovations which I won't talk about, but I think that the essence of my presentation is to say that, with the mobile technology, which is currently in the hands of millions of Nigerians as well as Kenyans, there's the opportunity to use that tool, that device, to leverage additional funding, but also create access to healthcare services, and even monitor the kinds of health outcomes and the care being delivered in a more structured manner. So I'll end there and hand back over to.
Great. Thank you very much, Njide, for that very excellent presentation. Super comprehensive, really appreciated seeing all the various use cases that Farm Access has managed to develop and deploy. We'd now like to open it up to the audience to administer a poll based on that, and also both the previous presentations regarding which aspect of UHC progress you think digital financial services for health can best serve. So I'll launch the poll now. We'll leave it open for a few seconds, and look forward to seeing your responses. And we'll go through them during the discussion at the end. Great. Okay, thanks a lot for those responses. We'll now dive into the next presentation. So Matt will go ahead and describe a little bit how DFS4H can support the UHC agenda in a couple of pretty different Asian countries to what you've just heard in Nigeria and Kenya. Thanks. Take it away, Matt.
Great. Thank you very much, Sri. I'm just going to share my screen. I have to say it is quite a tough act to follow, Najide and also Liz and Sri, but I will do my best. So just by way of introduction, Common Health is a purpose-driven company that is focused on using mobile technology to advance universal health coverage. As an entity, we're relatively new. We started in mid-2019, but really building off of work many years before that through different vehicles across Asia and also in Europe. And so what I'll try to do today is just to share maybe a little bit of a provocation around this connection of UHC 2.0 and digital financial services for health. I'll provide a couple case studies from some of the work that we've been involved in over the past few years, and then also potentially raise some questions that we can expand on in the discussion as well on the future. So, you know, the starting point and what I'm going to try to do in about the 20 minutes that I have with you is try to convince you that LMICs can leapfrog to UHC 2.0 using digital financial services and other mobile platforms. And, you know, this is meant to be provocative because I think, you know, what we're seeing now is that even UHC 1.0 has had huge successes, but also real challenges. And the question is going to be, what comes next? And where does that leadership come from? And the reason why I'm hopeful about this and optimistic is because really LMICs have done this before. And I think the other speakers touched on this, but what we see today, not just 5 billion mobile phone users, but 3 billion smartphone users. And interestingly, that's really coming from places that might not have had very much access before. So even if you look at a place like Myanmar, which really didn't have much penetration of telecom infrastructure at all a decade ago, Myanmar now has mobile phone penetration, smartphone penetration that is roughly equivalent to Germany. So, you know, there's a really exciting opportunity given digital financial services infrastructure, given other digital infrastructure for LMICs to define a new model. And, you know, it really is necessary because, you know, again, we describe UHC as really being about access to essential health services, financial protection for health. And we would also argue as Common Health that it also becomes important to look at addressing future health risks and mitigating those risks. And what we see looking at the context in Asia is that there are real challenges. And I think what you see, the main takeaway from the data overall, and these will be things that, you know, many folks on this call will know deeply, so I won't spend a lot of time on it. But really what we see are challenges across all of those domains. So overall, you know, really limited human resources for health, primarily concentrated in urban areas. The second, and I think, you know, this is comparable to the Nigeria example, high rates of out-of-pocket spending on health. And what that means is that families are more vulnerable to financially catastrophic healthcare events. And this changing disease burden, moving towards more complex NCDs that are, quote unquote, catching up to higher income countries. And then for the two countries that we focus on, Bangladesh and Myanmar, you know, if you look within that, Bangladesh and Myanmar, I would say, are pretty extreme examples even within that group. So, you know, real challenges, as you see on the left, around human resources for health, very high rates of out-of-pocket spending on health. So Myanmar is the highest in the region, and still struggling with these challenges around chronic diseases. For example, there's 5 million people living with chronic kidney disease in Myanmar today, and a significant share of the population of Bangladesh are diabetic or pre-diabetic. So as far as this need for us to look at new models, it really does feel like we're going to need to find new models, get to a 2.0, because UHC 1.0 is just not going to be scalable, and it's just simply not going to work. And just to dig a little bit deeper into this is just a bit of a comparison between Bangladesh and Myanmar. What we see again is obviously Bangladesh's population is far larger, different performance and achievements on some different indicators, still relatively low per capita health expenditure across the board, and relatively low levels of spending on health as a share of GDP. And relatively high rates of catastrophic expenditures at the 10% level. Again, some of this data, admittedly, this is from the latest data that we had on the WHO, is relatively dated. What is really exciting is that we are seeing some shoots of opportunity coming up. The SSK scheme in Bangladesh is really a first experiment around covering households in low-income areas. The SSB scheme in Myanmar has been looking at formerly employed workers. Both of these schemes, I think, are important first steps and signal the intention of the government to do more. Neither of these schemes really leverage, to a great extent, digital and mobile technology to drive change. And so, there are real opportunities there to add even more value through some of the platforms that have been discussed. And in both cases, these countries have ambitious plans to get to universal health coverage in short order. And this is something where these initial projects are part of that. But also, I think one of the things that I've just been really impressed by through my 5 years of living and working in Bangladesh, followed by a while working in Myanmar as well, is an openness to try new things, and to look at creative partnerships to bridge the gap and to accelerate progress on UHC. And I think that's something that has been really consistent at all levels of society and from all stakeholders that we've seen both in Bangladesh and in Myanmar. And so, as far as those creative approaches that I just mentioned to engaging new partnerships, what might that look like? And from our perspective, I think what we see is that digital financial services and those other platforms, particularly when we start to see higher rates of penetration on smartphones, but not limited to that, is that creates a real infrastructure and a foundation for achieving some things that we believe are going to be necessary towards UHC 2.0. The first piece of that is going to be mobilizing new sources of health financing. So many of you may have seen the report that came out from the World Bank in July of 2019 that outlined an annual health financing gap projected for 2030 of $176 billion. Even with aggressive revenue raising activities from governments, that gap would shrink to $122 billion, but still significant. And unfortunately, what we're likely seeing, if anything, is that the fiscal picture for health in many LMICs, as a consequence of lower revenues coming in and broader economic challenges due to COVID, is in actual fact getting less optimistic. So it's going to be really important that we find new ways to mobilize sources of health financing that complement and support national health insurance strategies. And that can be from external funding sources, that can be from the private sector, and that can also be from households themselves. And digital financial services, as I'll share in some of these case studies, can have a really powerful role in driving that. The second thing that we believe needs to happen is we have to do a better job of integrating and aligning financing and provisioning. We see that there is significant misallocation of resources and real waste due to lack of alignment between financing and provisioning and between incentive problems across health systems. I think Najide touched on some of these from the Nigeria experience. Those are things that unfortunately we see consistently also across many LMICs. And so there's a real opportunity to get out of this trap that we see in high-income countries as well, of this lack of alignment between financing and provisioning and, in actual fact, outcomes for patients, which is really what matters. The third piece is looking at how can we scale up innovative care delivery models. And that has implications both in terms of reaching people, and I think Najide touched on some of those. I will share more as well in some of our work on this. But also those innovative care delivery models really have the opportunity to drive outcomes and access without necessarily correspondingly driving cost and spend in the same way that, say, traditional brick and mortar approaches have taken. And so there is a real moment, we believe, to scale up these models. And then really the fourth pillar that we believe is going to be important is shifting away from episodic interactions and moving more towards proactive health management. The likelihood that we are going to be able to get a handle on NCDs without a shift in the way that we think about delivering care for people living with NCDs or who may be at high risk of them is low. So we're going to need to figure out how we move away from healthcare systems really globally in both low resource and high resource settings that are structured for delivering acute episodic care and move towards proactive health management. And we believe strongly that digital financial services and mobile platforms can help us do that. But there is much more work to be done. So just to give you an example of what this literally might look like, as far as the applications of mobile technology, obviously one of them is really around expanding access to financial protection. And that can be both delivering a claims experience and a payment experience, but also mobilizing and collecting premiums. As I think we all know from even our own personal experiences, telemedicine has really exploded as a new model for delivering care. And we're seeing that really across every single geography. But also this ability to drive health education promotion and primary and secondary prevention, again, on this piece around risk management, and the opportunity to meet people where they are. And, I was so excited to see Najide talk about, reaching people on Facebook, because we really do have all these other platforms out there. Not everything needs to be done on new apps. A lot can be done by what we would describe as meeting people where they are, and finding the best way to engage with them where they are. So what does this look like? And for us, I'll just share a couple examples. So one project that we built and scaled was called Tonic. This was launched in June of 2016 in Bangladesh by Telenor Health and Grameenphone. And really the idea here was to bring together, as you can see here, several different components around digital health and health financing into a subscription in a combined way. And leveraging both the distribution power of telecom operators with the payment mechanisms available through things like mobile airtime to scale. And over the course of roughly 24 months, we were able to scale access to 5 million beneficiaries. So the largest health insurance scheme in Bangladesh by number of lives covered. And then really the focus shifted to deepening that engagement to provide more comprehensive coverage. And again, digital financial services played a role really across every dimension of this, from looking at how do we collect what we would call subscription fees to support premiums for the insurance piece, but also how do we provide that payout in a way that is both efficient for us from a resource utilization perspective, but also that is accessible for beneficiaries so that they can access benefits when they need it through mobile money, instead of having to go through the process of creating a brick and mortar bank account. And I think, this other piece around looking at opportunities, I think Shri and Liz touched on this, on really routing more payments through digital financial services gives us the opportunity to leverage economies of scale. And one of the things that we focused on was on using our economies of scale to drive discounts and cost savings to reduce out of pocket through that mechanism. So again, both leveraging from the financial services side, the risk pooling function of health insurance, but also the strategic purchasing or provider negotiation aspect of health insurance. And what digital financial services also did is it really opened up new distribution channels. So what you see here is Shasta Cormy, who's a community health worker, who was selling tonic subscriptions through scratch cards. And again, that's enabled both by cash transactions, but also more importantly through mobile financial services. So, I think tonic is a really compelling example of how through the right partnerships and through the right platforms, it is possible to scale up services that have a meaningful impact very quickly. The other case that I would talk about for us from Common Health as we look at taking the work forward is on how can we really deepen both the engagement and the level of coverage for beneficiaries to make something much more comprehensive and consequential. But also, how can we start to really drive integration? And I mentioned before that, integrating financing provisioning, we believe is going to be a really important part of enabling us to get to the next level of UHC. And that's something that we've really been focused on as Common Health is not just having those components, but tying them together. And for us, we believe very strongly that, the first port of call for anything around health needs to be a healthcare provider, and a healthcare provider who is empowered not just to deliver care in that moment, but for that provider also to be able to do all the other things that a great GP does. And we all know that really in our experience, hopefully with our GP, that GP is not just providing a consultation on an episodic basis. She's also making referrals, advising us even on issues around cost and on decision making, right? On helping change behavior. And so having the GP as the front door to health that then can start to connect people with resources, even in some ways serving as a caseworker or a social worker, we believe becomes very powerful. And we think that the adoption of telemedicine becomes a way to do that. But also when it is really coupled with high quality insurance with a great user experience, other supporting services, and connected through what we would argue is online to offline. So really looping in resources from more traditional models, including in this case for a common Neurapod, factory clinics, and looking at how do we integrate those clinics and upskill them so that there's a seamless experience through, say, sharing of electronic medical record data between telemedicine services and physical services. And I think what's exciting is that, really there's an opportunity to do this work now with the adoption of digital technology, and you have to have that be very cost effective. So really the ability to start with services that cost, at or below 1% of income level, even for folks that are low resourced. And again, looking at ways that we can drive even more value out of that. So, we're hopeful both with, I would say, the groundwork that was really laid with Tonic to show that it's possible to do provisioning and financing together, to show that you can really walk and chew gum at the same time. That now the next step is integrating these pieces, and that's really going to be a major focus for us now, both in Bangladesh and also through our emerging work in Myanmar as well. And again, just to highlight a bit more about our delivery approach. So really our focus is on having a central platform that can enable all of these services, but plugging into local partners. So number one, we never do anything on our own. Number two, we always integrate with both the public and the private sector. So it's important that we are agnostic about the providers that we work with. So that can include both people that are going to public hospitals and private hospitals. But also, we're really excited to look at how for the insurance component that can be underwritten, not only by private health insurers, but also that we can look at underwriting partnerships with national health insurance schemes, where they provide the back end, and that pooling, instead of being done in a private health insurance model, that risk pooling is still being done in the public sector. So we're really agnostic about about where that happens. And then, of course, it's about really, again, connecting in both on the provider side, but also looking at how can we find new channels to reach people, to mobilize those contributions, particularly from informal workers, where the question around how do we get informal workers to contribute to health insurance schemes doesn't really have obvious answers. And so looking at how can we drive contributions, whether those are voluntary or legally mandated, how can we make that effectively work from the informal sector really does take engagement at the front end from many local partners. And we've been really excited to build that experience working with different stakeholders. So, my last slide, to make sure that we have some time for discussion, is really thinking about this question on, what does COVID change and what does it not change? And I pose these as questions instead of as statements because, I don't think any of us really know the answers to this. And I think it's, more interesting to think about these and to have a discussion around them than to necessarily have a strong point of view on where we think it will go, right? But I think one question that we have is, how are general consumer behaviors changing? And I think, for us, some of the data that Liz shared around, look, we're still seeing, I would say, pretty stubbornly DFS being focused on cash in, cash out, and peer-to-peer. And while we are seeing some changes on the use of DFS for merchant payments, for recurring payments, I would say prior to COVID, both the consumer adoption around merchant payments and the technical capabilities from DFS platforms to handle things like recurring payments and premium collections have been limited. And so I think one big question is, how do we see COVID and these changes, as Shri mentioned, 5 years progress in 8 weeks, how do we see those changes impacting overall usage of things like e-commerce and DFS? I think the second is, how do we see health seeking and service utilization changing? And, back to this point around new delivery models, how much of that change in adoption of telemedicine will be lasting? How much of that will be something that sort of levels out at a new normal that is higher than previous usage, but not as high as at the peak of the coronavirus pandemic? And then what are the other ways that COVID will change health seeking beyond just traditional telemedicine? So really having a point of view on that and evolving that understanding will be an important determination of where we go from here. And then I think the last piece is how are attitudes around social protection changing, and how are delivery models for social protection changing? I think we're seeing, really exciting progress on things like cash transfers shifting from being done through physical cash through digital cash. We're seeing social protection as an issue becoming something that is probably top of mind to a degree that at least certainly I have not seen in my career. And what implications will that have for willingness to invest, whether that investment is being done by governments on behalf of their citizens, whether that investment is being done by the private sector, or whether that is being done by families themselves. So I think, we're in a really interesting time. There's a great opportunity, again, I think, to say, not can we leapfrog, but actually recognizing that LMICs are in actual fact leapfrogging today. And really the question is, how can we support and accelerate that leapfrogging? So with that, I will turn it back over to Shri. Thank you very much.
Great. Thank you very much for that, Matt. Super insightful presentation and really interesting to see how some of these innovative products you've worked on are able to address a current need, but also have the potential to feed into government reforms at a later stage. We now have a second poll question for the audience. Given everything you've heard throughout the session, we would like to hear from you what you think is the most important precondition for digital financial services for health to support UHC aspirations. So I'll just turn that poll on now, and we'll give you a bit of time to consider the options and respond. Thank you. All right. Thank you for all your responses. It's great to see a strong mix of responses. Um, and so now I'll hand it over to Arun to review some of these poll responses and also to take us through a moderated discussion session, answer any of your questions. Thanks, Arun.
Thanks so much, Shri. My name is Arun Datta. I'm a Senior Technical Director, Health Financing for the Health Policy Plus project and also an economist at Palladium. I thank all the presenters. It's been amazing hearing about the use cases and also hearing about some general thoughts on how digital financial services for health can help and benefit UHC. So let's take a look at what you have told us in terms of the poll response on how you're feeling on this topic. The first question was a general question on how can UHC be best served by digital financial services for health? And we posed some general points around UHC that we are familiar with around population coverage, health system responsiveness, especially paying providers, improving financial protection through savings accounts, which was a topic that Njide talked about, and then expanding access to services through digital, remote delivery and payment. And of course, we posed a counterpoint, which is that DFS for H cannot really serve UHC at this time. So the good news is that nobody picked that last point. I think the responses are fairly even. We do not have a lot of folks really going for the savings account option. We see a lot more interest in health system responsiveness and paying providers, which is already happening. I think we heard from use cases in Nigeria and Kenya where that is happening, and certainly the design in Bangladesh for Tonic and also the new Nirapod product from Common Health has perspectives of paying providers. So that's great that our audience also feels that can work. And then we have some interest in terms of expanding access to remote delivery, certainly the last mile barrier and how to span that barrier, how to leapfrog the last mile where connectivity through fixed lines really never got to those places. We can leapfrog a lot of that challenge through digital. So I think we saw some interest there. Insurance came in third, but I think this will be another issue that intersects with the question that was raised in the chat about trust, which I will come back to. But I think insurance will definitely be an aspect that in low insurance coverage countries, digital will help to be an enabler, expanding insurance coverage, whether it's through microinsurance products like the ones that Common Health has and Matt Guilford told us about, or integration with existing social health insurance platforms as what Njide told us about. Looking at the second question, I think this is an important issue around how we get there and what are the possible barriers. So we raised to you several issues that Liz and Shri had talked about right at the beginning of this session. And I think in terms of what you are picking, it seems the most important things are, of course, the regulatory framework. Yes, we completely recognize that proper regulation can be much more than just a check or accountability system. It can really enable that underlying sort of platform for growth, for a jumpstart. So regulation has a lot to do, and the government can be an important steward of digital financial services for health. But we also see here your interest and your continued reminder to us about how trust issues. I think one of the last slides that Matt showed us really sort of also brought us back to this, that if users' trust in these services, doesn't sort of build up over time, how well does the system perform? And can we really expand and scale up if the trust is not there? So actually, while I do have some questions that I want to pose to our presenters, let's start with the trust question. Our audience member, Diwakar Mohan, raised this question, which I think is very, very useful as a frame. So there's digital competency, whether the person on the user side perceives themselves to be competent and manage well the digital transaction, understand the risks and the benefits. And then on the other side, we have a sort of a trust in an abstract concept, which is digital money, money that, came in as cash and then got transferred and became M-Pesa or some other monetized form. So how well do these things work together? Do they actually go, in fact, hand in hand, trust and competency? And what can we do if there is actually a disconnect there? So I know that while you were presenting, Matt and Jide, Shri and I had a quick discussion. So I'm going to allow him to start with some thoughts on this, and then we'll come back to both of you, starting with Njide and then going to Matt. So Shri, do you want to respond to Divakar's question?
Yeah, sure. Thanks, Arun. And I agree. It is a great question, one that I think is very at the top of people's minds, particularly around this trust aspect. So I think there's a couple of things. One, firstly, of course, is the appropriate regulatory framework being in place. But I think what we're also seeing especially through the COVID pandemic, is that use is a really important facilitator of trust, and Jide touched on this in her slides where she talked about one of the enablers being mobile phone penetration, being the demographic dividend. This is actually what I think is going to help to overcome some of these trust and competency issues, is that there's an increasing use of mobile technology, and with that comes then the opportunity to engage with digital financial services. And there have been studies actually that have come out just during the last few months, one done by the bank looking at garment workers in Bangladesh who had to receive stimulus checks through a digital platform in recent months. And what they found was that just that first exposure to receiving digital money and then having to access it and being able to use it in the community was actually really pivotal and transformative in making these workers now more savvy as digital users of financial services, and also having also some positive externalities to the businesses in the regions of the factories, making them more aware of what their rights are in terms of the pay that they're entitled to. So I think coming back to our original framing, now really is the time to expand DFS, precisely because there's been a kind of a forcing of use through some of these stimulus packages. Thanks.
So in a way, what you're bringing out there, Shri, is that the COVID situation, because it was a special event, a special risk, it forced onto certain individuals and actors the need to use digital services, whether to receive a social protection, social assistance payment, or to engage with their employer. And through that use, whether it was fully voluntary or not, there has become a sort of a wave of usage that in itself engenders increasing trust. And I think we've seen this with other electronic and digital technologies where first adopters can lead to a demonstration effect and then engender trust among their communities. But I want to bring it back to Njide and Matt. Njide, would you like to talk about this issue of trust and competency in terms of use of digital products? And is that a barrier? And if it is a barrier, how do we overcome it?
Okay, so I actually think that trust is quite fundamental, and I'll use the case of Nigeria. Initially, when mobile money was introduced, those who tried to use it to pay for premiums, it took on the average 4 days for the monies to get to the payer who was collecting the funding. And of course, word of mouth, they've stolen my money, it doesn't work, and so on and so forth. So that totally reversed any advocacy that had been done for mobile money, albeit in a very small segment of the population that was already trying to adopt it. The second thing is that, Nigeria, 39.8% of the population is unbanked. That's about 60 million people. And unfortunately, these are the people that need the financial services the most, as well as healthcare services and other benefits. So as far as the government is concerned, they don't even exist. We can't find them. We don't know who they are. So there should be a need to breach that gap. And there's already advocacy that has started to get mobile money up and running, to accredit mobile money operators. You won't believe it, that Nigeria, as big telcos as they are existing here, there's only one that has been given that license, and that's Nine Mobile. And you probably have never heard of Nine Mobile. There's MTN, there's Airtel, but the government didn't give them any license. So again, it goes back to vested interest of the bankers, because they are actually the ones blocking it. So regulation and understanding that, the fact that these guys are using mobile money doesn't prevent you from making your profits in financial services for those that have bank accounts. So there needs to be some kind of alignment, but it has to be seen through government, and that people can use and can trust the system, and not that their funds are going to disappear. So the reason why it's not, the uptake is not as much as in Kenya is because the two giants, the Central Bank of Nigeria, the financial institutions, the banks, are actually against the uptake of mobile money, which is quite unfortunate, because it could really, really open up the economy, just like it has done in Kenya. So I think it's more about advocacy than anything.
Now, that's a really important point. I mean, here is a case where, unlike what we think should happen, where stewardship should really stand behind the mobile money system and the process, especially if there's a delay in the account showing your balance, which is really a moment of trust. Here you have a situation where perhaps, as you said, due to lack of competition and certainly regulatory frameworks acting more as a barrier to full market expansion and market growth, we have a situation where perhaps the growth is not as fast as it could have been compared to East Africa. So that's a very interesting counterpoint. Matt, what are you seeing in Asia? I mean, I know the regulatory systems there can be equally challenging, but what's happening in terms of increasing trust, both stewardship as well as from the demand side?
Yeah, I mean, I think number one, it's an issue that we think about quite a bit. So it's a really good question. I guess the first thing that I would say is that, back to your point about competency and the relation with trust, consumers are not wrong to be mistrustful, right? So, this mistrust and skepticism of financial services is in place for a reason, right? And it's because a lot of people have had bad experiences, and granted, that might not have been from many of the players that are around today, but the reality is that that mistrust was earned, and so there is a deficit that we need to overcome. I think as everyone said, the opportunities that we have to show people that it works, especially around now, even with things like cash transfers and other types of payments, that's a really good start. I think one of the big questions in our mind is how much of that trust will transfer to different applications, will transfer across different applications of DFS, right? So somebody may trust you that, okay, you're going to be able to get my money from me to a healthcare provider, and that it will actually show up. Now, whether that trust extends to, I trust you that when you say, I will pay your claim when you have to go to the hospital, and that will actually happen, that's a question, right? I think from our perspective, we think that there is a significant amount of work that will need to be done to build that trust, not just about general use of DFS, but around specific use cases. So it may not be enough that somebody has used DFS for a cash transfer. They may actually need to see that it works for insurance in order to trust insurance. And we kind of don't know that, but that's something that we need to see, right? How much of that is fungible, so to speak.
Mm-hmm. Fascinating. Yeah, I think this is going to be an interesting area of even research to help us understand how these trust issues manifest. We'll be looking at hopefully a wave of implementation research around these topics based on asking consumers. But let me switch to another question that came in through chat, and this one is to Njide. Of course, we have MTIBA working fairly in an integrated fashion with the National Hospital Insurance Fund in Kenya. And you showed us in your use case how the premiums can be transferred through the CarePay application. But across Kenya and Nigeria, what is your sense of how willing is the sort of state insurer, the government-backed health insurance scheme, whether it's at the subnational or the national level, how interested are they in using these digital technologies to and integrate them fully into their back-end systems, whether for premium or for claims management? Or do they see these as being external and provide only lukewarm support, if any? Over.
No, this is fully integrated. MTBA is the premium collection platform for NHIF in their journey towards UHC, starting with Kisumu County. So any monies that are collected through MTBA is channeled directly to NHIF. Of course, there are other channels to make payments to the insurance scheme, either through the office, NHIF office, or I think they have other designated agents, but MTBA definitely is integrated into NHIF. In Lagos, that's CarePay is the platform for enrollment. So from the payment of premium through their web portal, all the money goes directly into the Lagos State Health Insurance Management Scheme. So it's not, it's actually the backbone of operations, and not just for collecting monies or premiums, but also leveraging, there's a wallet layered in Nigeria, a wallet layered on top of the actual premium itself, which is receives funding from Global Fund to treat malaria and HIV/AIDS and tuberculosis. So, you know, we're seeing this as really the backbone upon which you can layer other financial services. And like I mentioned during my presentation, the federal government is now trying to use this platform for conditional cash transfer. And the innovations are coming out of it now. They're seeing the possibilities. So a person designated as an indigent gets about 6,000 naira a month. I'll figure out how much that is in dollars. But now we're saying if you save 1,000 of that 6,000, which is not too significant, and over 4 months, you can actually pay your premium for a year. So if we're telling the government that, that you can use this digital channel to actually provide health insurance to these people who you're calling indigent. And so we're seeing that, again, another example in Lagos State, there is a scheme where you give loans to healthcare SMEs. It's, you know, artisans. It's a way of supporting small businesses. And now we're into that loan repayment. They've bundled the annual premium such that it's, you know, it's spread over a year, because we said to them, if you give them a loan and they go off and die, or they're ill and they can't even treat themselves, then what benefit do you have? So we're looking for now innovative ways to leverage other services into this health insurance. So yes, it is the backbone of the operations, not just in Lagos and Kwara and some of the states that we are supporting.
That's good. What you bring up there, I want to touch on it and pose maybe our last question to Liz and Shri. So I think what Njide mentions there at the end about how to layer different financial services and reach different populations. Maybe, you know, these are populations that have different needs as well: social protection needs, social health insurance needs, or access to finance in the case of a small business owner. You know, obviously this is bringing up issue of multi-sectorality, because there's the health sector involved, but there's also the social protection sector involved, and possibly the economic growth, industrial progress sector involved. What do you think we can do to promote this? Or do you think that technologically, in terms of development costs, it's probably still going to be a more sector-driven approach to DFS? Because we're now moving beyond health, DFS for health and social protection. So in your sense, what can be done to increase multi-sectoral action, but also what are the possible barriers? So let's start with Liz.
Thanks, Arun. This is a great question, and I think it's clear from all the presentations today that there's no way to go about this alone just for health. Just like there's no way to go about UHC 2.0 from just a health lens, right? And I think that's true when we layer in the digital aspect of this as well. I think there have been significant improvements in trying to link social protection in general to health protection, and we're seeing that within how information is being shared across different sectors. Really trying to reduce the silos across different vertical systems, even within health, but outside of health. So I think information in general is a huge enabler of that, to break down those silos. I think it's clear from the first question about trust that this absolutely has to be integrated into improvements within the digital financial services sector in general, and banking and regulation. We can't do this without having that trust built in the system and having the buy-in from the banks, as Njide said. I think there's several other layers of integration, just even within the health sector that we need to be considering. Thinking about how, and we've touched on this briefly, but how does DFS for health fit into the overarching, digital health ecosystem and digital health architecture in a country, and really linking it back to the general approach for UHC. I think, it's interesting when you look back in Njide's slide about how they designed the scheme. We saw, a big slide with lots of different components across across the entire spectrum, and there's one little component, right, that's about digital or ICT or technology, right? And I think that's key, that it's technology and digital as an enabler, but it really can't fix, it really can't create a system that doesn't exist, right? So I think we have to be thinking about it in the context of the program that is already established, and really be using it as an enabler and a facilitator of those linkages, and reducing, that fragmentation in the spaghetti that Njide's slides also clearly, pointed out.
Thanks, Liz. Shri, do you want to add to that?
Yeah, sure. I think I agree with everything Liz said. Also agree that it is a very complex issue to try and address. But I think for us to fully appreciate the benefits of DFS, an integrated approach is one that would allow the scale effects as well as the efficiencies to be fully realized. But to the point about multi-sectorality being a major challenge in actually facilitating this, I think perhaps a more incremental approach may be advantageous to serve the most pressing or priority needs of a particular population with a DFS for H enabled solution, whether that be health insurance premium payment, for example, and then tying in additional functionalities if that would be potentially, finding providers, networking with them, and then facilitating provider payments at some point. That would, I think, be probably the most feasible approach to addressing this question. And then obviously building into a broader social protection framework will be the end goal, recognizing that health protection is really just one subset of the broader social protection needs for an individual or population. Thanks.
Thanks. Yeah, so much hope, so much promise. I want to ask Matt for his absolute soundbite type response on this. So, Matt, all this potential exists. We're talking about so much in terms of the ability of the technology, but what about the feasibility of the technology for the operator? I mean, do you think that this technology, the DFS for health expansion, can be profitable and can cover the cost of software development all the way to ongoing operation? Do you think that this has legs in terms of financial viability?
So thanks, Arun. That's a complicated question for a soundbite, but I'll try my best. I mean, I think that the soundbite is yes. If I'm allowed a couple more sentences, I think what I would say is yes, but also I think we need to be thoughtful about how are we balancing impact and viability. And what I mean by that is, look, I don't think there's any question that there will be economically viable models around leveraging digital financial services for health. Many of those will be driven by the private sector venture capital ecosystem, right? That will just happen. I think I think the question on those models will be, are those impacting the people that need it most, right? And the answer to that is less clear. So our view is, and I say for us, and I would say probably to some extent for farm access, but I won't speak for Najide, we're kind of trying to thread this needle between being viable, but also not only serving the top end of the population. And I think, one of the things that we do need to look at is it may be that to really reach through viable models, families at the base of the pyramid, families in the lower middle class, that education and literacy around these products and that demand generation may need some support. So I am 100% bullish about there being an opportunity here. I think the question will be, how do we make sure that that opportunity is focused on serving the people that need it most? And that may need some catalytic investments. Over.
Thank you. Yeah, no, thank you, Matt. That helps. I think so. Just to sum it up in terms of what we've heard over this exciting, interesting webinar, this is a digital moment that we're living in. It's no longer a question around innovation or digital innovation added on to an existing stream, a financial payment or a financial service. We are already in a digital age. So I think what we're talking about here is that the first movers have moved. Now the question is, do we have a follower pack that can now expand on those services, continue to add use cases, and most importantly, start to integrate these uses, these functions in a way that totally and fully serves the needs of vulnerable populations as well as the middle classes. And I think we are going to see that as just a question of where and when. And I think the trust factors that we have raised in this conversation are going to be important, but certainly that's where the government stewardship and the government interest in scaling up these technologies has to feature. And we have to get past barriers that some particular regulatory system may have placed. And I think that is going to happen because the pressure from the demand side is just going to mount. So this is really an exciting moment. It has been an exciting moment for a while, and COVID has certainly made it even more acute. So let's keep watching this space. I want to thank our presenters and, of course, the HSR conference organizers for this opportunity to talk about this subject. And hopefully you will see this recording available through our organizations at a future date. So thank you very much for your time, and hope you have a very good day or good evening wherever you are. Thanks so much. Bye-bye.
Thank you very much.